We know, like my previous speaker, Dr. Vadivar, covered amply about the extensive invasive approaches, understanding. So, I am going to talk on another corner of hypertrophic cardiomyopathy management, a drug which is not very freely available in India too, available in the West regularly, and the usage is also limited. But it gives one opportunity to learn about hypertrophic cardiomyopathy. The drug first approved in 1977 for use of treatment of atrial and ventricular arrhythmias. It's a class 1A antiarrhythmic agent, typical of affecting the sodium channel, slowing phase 0 and prolonging the action potential. But what is interesting for a hypertrophic cardiomyopathy patient is the ability to be a negative inotrope agent. So it slows the acceleration of the LV ejection flow, prolongs the flow acceleration time, or delay or abolish the mitral and septal contact. The antiarrhythmic efficacy is not the main one, but it does have a role in preventing paroxysmal atrial fibrillation as rhythm control, rarely as a rhythm control. To see in this slide, you can see the idea of using the drug is when the hypertrophic cardiomyopathy is a dynamic and progressive disease. So, you allow the obstruction to remain there. The pressure gradient increases, it is going to narrow the orifice further, increase stimulus for the hypertrophy. So, the progressive narrowing of subaortic obstruction going to occur, leading to progression of the disease pattern and all this morbidity or a fatal outcome. So, if you try some drugs, if you do anything to reduce the subaortic gradient, that is going to play a big role. Apart from the direct effect of the disarray of muscle fibers, arrhythmogenesis, all other things, the obstructive element can be prevented, which can have a positive role. So, the use of this drug or any method is reduction in both resting and exercise gradient particularly. Disopyramide known to show a dose-dependent reduction on this and more resting gradient reduction than beta blockers. This is an article published in 2010 American Journal of Cardiology where patients who are already on beta blockers, when they were treated either with calcium blocker like verapamil or when they were given disopyramide seems to have a better influence in reducing the percentage change of LV pressure gradient compared to even calcium blocker. That is in additive to beta blockers. But when we use this drug, though the drug is very old, the familiarity is less because of unavailability, but look for renal function, look for dyselectrolytemia, look at particularly the QT prolongation, and look at structural heart disease and coronary artery disease in this patient, particularly LV dysfunction, and look for the coronary arteries. And assessment of the other side effect, anticholinergic effect, like benign prostatic hypertrophy, urinary retention, or in people with glaucoma. The initiation is typically, the sustained release is available, but commonly advised is use 100 mg twice daily. Keep checking. There are varying approaches. Some of the centers in United Kingdom, they admit the patient, they watch him. In the United States, they keep him as an outpatient and watch them. So ECG, you can check it periodically within the first 48 hours and in the first week, and look for QT prolongation particularly and echo center gradient. And uptitrate dose up to a point of 600 mg a day, provided the patient tolerates it. And look for important adverse effects like proarrhythmic effects secondary to any of the antiarrhythmics, more so, and in the person of ischemia and heart failure. That is why I said we should look for it. And the anticholinergic effect we can mitigate by using pyridostigmine in this group. So we can try that. And paradoxical hypertension secondary reduction of LVOT obstruction has been reported. So be prepared to add other antihypertensive drugs at times. And drug interaction, particularly like CYP, cytochrome 3A4 metabolism, and the use of drugs like macrolide antibiotics, better to avoid in this situation. Inducer like rifampicin, barbiturates, phenytoin to be avoided to avoid this type of lethal arrhythmias or side effects. And combined with class 3, again, like drugs like amiodarone, going to increase the chance of QT prolongation and its own complications. So, the other consideration, disopyramide monotherapy can paradoxically increase the ventricular response to atrial fibrillation by increasing the AV node conduction. And in patient, normal QTC at baseline can be initiated on the outpatient basis. This is what the United Kingdom approach is. And this is only a trial available, 2005, a multi-center trial of 4 centers, 3 from US and 1 from UK. What they have looked at is patients with hypertrophic cardiomyopathy who received a non-pharmacologic invasive intervention or medical treatment only. And they see what all the group received disopyramide. So people who have been treated as per the expectation, as per physician discretion, but they divided 2 groups. Apart from the regular management, invasive management, whether they received disopyramide or not, what they found was in the entire group, in a retrospective analysis, as you treat with them, adding disopyramide seems to have an influence on the gradient and also on the outcome. That's what. So seems to be useful. But today, the guidelines gives only single line. Because only we have limited data, retrospective analysis, though they give a thing, we would love to have a proper RCT prospective, which has not been done. So, though it is there, their recommendation today is patients with obstructive hypertrophic cardiomyopathy who have persistent severe symptoms attributable to LVOT obstruction, despite beta blocker and calcium blocker, adding disopyramide in combination with one or the other drug is preferred in this group. This is the current recommendation. I will stop here. We can have a detailed discussion on hypertrophic cardiomyopathy, various things. Okay, thank you.